So welcome everyone. We're so pleased to host today's webinar. I'm going to do a quick introduction and then I will hand over to our speakers. So my name is Amy. I'm the one that's been sending all the emails. So I'm a speech therapist by background and I now work as clinical specialist with Phagenyx. So Phagenyx is the name of our company, with the Phagenyx System providing pharyngeal electrical stimulation. The treatment is indicated for use in adults with neurogenic dysphagia. We have a strong evidence base with over 30 publications, including 9 RCTs. This has resulted in the treatment being included in international guidelines, and of note, most recently included in the American Stroke Association guidelines. So today we have clinicians from up and down the UK who are going to share their real-world experience of using pharyngeal electrical stimulation. We're going to start with a patient testimony from the Cardiff team, then we'll move along the schedule. If you do have any questions, what I'd ask is that you put them in the chat. So myself and my colleague Sarah will be monitoring the chat. And if we've got time at the end, we plan to answer a couple of these questions. Also at the end, we will feature our contact details. So there'll be the contact details for the speakers, plus ourselves as Phagenyx employees. So if you have anything further, you can reach out to us. So now sit back and enjoy, and I will pass over to Sarah and Natalie in Cardiff, and they will share their video.
Hi, everybody. Yeah, so if one of the lovely panel people can tell us if there's any issues with seeing or hearing us, because now we can't see or hear anyone else, that'd be great. I'm Natalie Leonard, the clinical lead for speech and language therapy stroke rehabilitation in Cardiff and Vale, and this is the amazing Sarah Appleton, who's our highly specialist speech and language therapist in the neurology rehabilitation unit here in Cardiff and Vale. So we both work on the Landock Hospital site, if any of you are familiar with our area. And we've got a really lovely patient video to show you in just a second, and it's going to explain everything in much better detail than I would, but a tiny bit of history. So this is my first experience of working with Phagenyx with this case, and as you'll see in a minute, it has got me very, very excited about the future of what we're going to be able to do with this in Cardiff and Vale. But this young chap, Glody, came to us the 30th of August last year. He was admitted originally with a pneumonia, and he then became very unwell, ended up in intensive care and was intubated. And then during his time, he also had quite a few small infarcts when he was in intensive care. Once he was well enough, he transferred over to us on the rehab site, which was around the 10th of October. He'd just had a video fluoroscopy before coming over to us. And when he came over to us, he was unable to swallow even as any saliva. He was suctioning using Yanker himself to suction everything out, and unable to swallow anything. So we identified that he would have been a really appropriate candidate for pharyngeal electrical stimulation. And with the help of Lauren and Sarah Stangroom, we were able to get him some trial equipment. And well, I'm going to let Glody tell you about his outcomes, and then let us know if you've got any questions. Let's hope it works. Just share the window.
So my name's Glody Kenny. I've had quite a journey through the hospital. I first had symptoms of pneumonia. So I came to hospital, and when the doctors evaluated me, they found out that my pneumonia was quite severe.
So I had the privilege to look after Glody with our team here. He ended up on the intensive care unit.
So then they decided to put me in a medically induced coma. And during my coma, I had a stroke.
When he was transferred to us, his swallowing was really challenging. He was unable to swallow any food or liquids.
So when I first realized I couldn't swallow, it did eat me inside, knowing that I can't eat any food.
Team from speech and language therapy said to us that there's a device called the Phagenyx device, which does offer electrical stimulation to improve the swallow as well.
Speech and language therapy team were aware of a device called Phagenyx from the company Phagenyx, which is a pharyngeal electrical stimulation to treat neurogenic dysphagias. The system consists of this reusable base station and our catheters, which are single person only, and between the two we set personalised stimulation levels, which then provides the electrical impulse here through the catheter.
So when I first got offered this treatment, when I first heard electrical impulses, I thought it's going to be a struggle. So I was a little bit wary of it. So when I first had this treatment, all my thoughts were just disproven, because the treatment was the easiest thing. I feel like for me, that was the easiest thing to sit through. And it was only 10 minutes as well. So when I first felt that, and I knew that each session is going to be similar, I knew, oh, thank goodness I took this.
Within a very, very short period, swallow had improved completely. And in my professional career, I have never seen anyone improve as quick as this.
So my first ever x-ray of my swallow, I couldn't even get the liquids down my throat. They were just stuck at the top of my food pipe. My last one, everything was going down cleanly.
This has been an absolute fantastic story to share. And as I said, I've never seen someone experience this and recover as quick as this before.
Having seen Glody go from nil by mouth, not being able to eat or drink, or even manage his own saliva, within 2.5 weeks, he's had this treatment. We've repeated his x-ray and he's back onto normal diet and fluid. That's a recovery that we're not used to. It has been outstanding to see the progress that he's made.
Honestly, after this treatment, I'm so grateful to all the speech therapists just managed to get me on this. Like, this has literally changed my life. So honestly, everyone deserves this opportunity, in my opinion.
We're pleased to share that funding has now been secured to offer pharyngeal treatment to difficult patients at UHL and UHLT. Please note that this treatment is not appropriate for everyone. Phagenyx is offered only to selected inpatients within Cardiff and Vale. This will be decided by the speech and language therapy team based on clinical need and suitability.
Thank you so much, Sarah and Nat, for sharing that. It's a lovely story from Glody. I've seen that video a few times, but every time I watch it, it doesn't fail to put a smile on my face. So I'm going to now share the screen again, and we'll move on to Virginia.
Thanks, Amy. So my name is Virginia. I'm the clinical lead speech and language therapist at Barking-Havering and Redbridge University NHS Trust. I'll just wait for Amy to.
There we go.
Slides. So next slide, Amy, please. So our trust is located on the outer northeast London. We've got a bed capacity of about 900 beds across 2 hospital sites, and we serve a local population of approximately 800,000 people. We're the Regional Neurosurgical Centre for Essex, and we're also one of 8 designated hyperacute stroke units in London. And we see more than 1,600 stroke patients a year. So we have 16 neuroscience beds and 4 critical care units with a normal bed base of about 57, but this can surge to 67. So we actually have quite a large pool of patients who may be appropriate for Phagenyx. So we got Phagenyx in August of 2024 and started a pilot project. We initially identified possible Phagenyx patients in our critical care units via our instrumental clinics. So on average, we complete about 19 fees and 10 video fluoroscopy assessments per month. We considered patients for Phagenyx on the inclusion criteria of whether or not they had reduced or no spontaneous swallow, poor pharyngeal sensation, such as excess secretions or a high New Zealand secretion scale score, or if they had significant post-swallow pharyngeal residue. And we also considered them if they had poor laryngeal sensation or if they had a penetration aspiration score greater or equal to 6. So we picked greater or equal to 6 due to the limitations that we might have identifying aspiration on fees, either because of the secretions, residue, or anatomy obscuring the view, or obviously the intraswallow whiteout that you might get. We then excluded patients based on the listed contraindications as per Phagenesis, the company. So if any patients had a structural abnormality, so example, patients with fibrosis due to late effects of radiotherapy, or if they had a pharyngeal pouch, or if they were pregnant, or if they had a progressive neurological diagnosis, or if there was an implanted device such as a pacemaker. Once we confirmed that a patient was suitable for Phagenyx, we would then treat them, and the median time to treatment from the date of their diagnosis onset was 29 days, but this can also range from 9 to 166 days. The patient that we actually treated at 166 days from date of onset had been repatriated to us from a different hospital. So in terms of the number of patients that we treated in about a year's time, we treated 18 patients, but unfortunately one patient removed the catheter immediately after the first treatment session. So we excluded them from the data set. So that left us with 17 patients. And the 17 patients all completed either a minimum of 3 treatment sessions or a maximum of up to 6. And so we then also did a post-treatment follow-up assessment. We then matched those patients with a control group, which were patients that we felt would have been appropriate for Phagenyx in the time leading up to before we got it. So from about 2022, from when we started having some data, to right before we got Phagenyx in 2024. And so we found about 25 patients, but again, we excluded people who were contraindicated for it, or they had been repatriated to another hospital or to their local hospital quite early. So that left us with about 19 critical care patients who received the normal standard of care. So that could be normal tracheostomy weaning, such as cuff deflation or one-way valve trials, or above cuff vocalization trials, or even just normal traditional dysphagia therapy, sort of that watch and wait approach. And they also then received some form of follow-up evaluation, so either a videofluoroscopy or a FEES as well. In terms of the admission diagnoses, so you can see on the left side, the treatment group, the predominant majority of diagnoses were sort of like essential. So you can, it's all in the white font. So a stroke, aneurysm, TBI, or a brain tumor, which was then resected, or encephalitis. And then the other diagnoses were either bowel obstruction or surgical septic shock, but we felt that these were, the patient's dysphagia was more related to a critical care myopathy. In the control group, similar diagnoses in the sense that the majority of them were central, so a lot more, again, stroke, brain tumor, TBI, and again, critical care complications from that. So at baseline, they were very similar groups. In the Phagenyx group, they were around 55 years median age, with ranging from 44 to 79, and in our control group, it was median age of 60. Ranging from 36 to 82. We had more men in both groups, and a high proportion of them were both intubated. And our data collection for our control group in terms of intubation isn't complete, mostly because of patients who had been repatriated to us from overseas. We didn't have all of that information. Again, a lot of our patients were tracheostomized, and a high proportion of them all required enteral feeding and had a FOIS score of 1, which is no by mouth. So very similar groups. In terms of our outcomes, we looked at airway protection. So the graph on the left demonstrates the improvement seen in the New Zealand secretion scale pre and post treatment. So there's a reduction in the median score, which has been shown to be statistically significant. And the table below indicates the change in secretion management strategies. So you can see that post-treatment, a lot of the patients did not require any further drying agents or no longer required any suctioning. The graph on the right demonstrates the improvement seen in the maximum penetration aspiration scores pre and post-treatment. So you can see that there was a reduction in the median penetration aspiration score, which was also shown to be statistically significant. Overall, 76% of our patients had some improvements in their secretion management, and over half of the patients had at least 1 point improvement in their penetration aspiration score. So less patients were presenting with silent aspiration, which means that we could potentially rely less on instrumental clinics and have more confidence in our bedside assessments. So this kind of indicated that there has been an improvement in these patients' airway safety, which then leads us to tracheostomy decannulation. So we found that comparing our treatment group to our control group, that our patients had an earlier decannulation by 5.5 median days compared to those that received normal standard care. The outliers in our treatment group were not able to be decannulated for unrelated dysphagia complications. So we had one patient who had a subglottic granulation, and the patient that actually had the trachea for 103 days, we had 2 trachea insertions, and we treated him on his second trachea insertion. But overall, earlier decannulation of at least 5.5 days means that these patients can also be stepped down earlier from critical care, which has this flow-on effect of improving that patient flow and reducing nursing needs and the consumables, which can also have financial and operational benefits. In terms of oral intake, this graph demonstrates the change in the median functional oral intake scores from the baseline to follow-up and at discharge for both the treatment group and our control group. The improvement in the voice scores in the Phagenyx group from baseline to follow-up to discharge has been shown to be statistically significant, and the differences between the voice scores in the Phagenyx and the control group has also been shown to be statistically significant. So this essentially means we saw improvements earlier in the Phagenyx patient journey when comparing the 2 groups, and the median time to follow up from admission was 24 days earlier in the treatment group as well. So we were able to return patients to oral intake at least 20 days earlier compared to the control group. So then at discharge, unsurprisingly, a lot of our treatment group, a lot more of them were on oral intake, with 63% of them eating and drinking, and less patients relying on enteral feeding. Both groups had similar rates of patients who ended up eating and drinking at risk or with acknowledged risk. But overall, more patients were eating and drinking, and more of them were on level 0 and level 7 of IDSI. This also means that our ICU length of stay was reduced by a median of 10 days, which wasn't necessarily shown to be statistically significant, but then again, this also has operational and financial benefits. And because of the reduced length of stay in critical care, we also saw a reduction in their overall length of stay in hospital in the treatment group compared to our control group. So that was by a median of 21 days. In terms of a financial impact, an ICU bed cost is around £2,000 per day. And if we reduce their length of stay on critical care by a median of 10 days, and we minus the product cost, and we treated this on 17 patients, then that amounts to approximately over £300,000 in terms of cost savings. So we've demonstrated quite a significant impact in our critical care patients by using Phagenyx, and we're really pleased to say that we've managed to get ongoing funding from critical care. So now we have a lot more catheters, and it is going to be part of our standard treatment going forward. And in terms of our key learnings, we definitely learned along the way in terms of patient selection, the benefits of treating patients early. We obviously demonstrated quite good clinical outcomes and the cost savings. We didn't have any device or treatment-related adverse events. Obviously, there are limitations, however, in that this is a small sample size. It is a real-world pilot experience, so it doesn't have robust research protocols. We don't necessarily have standardized assessment protocols in terms of our fees or consistent time points with outcome measurement. But we have learnt a lot along the way, and Phagenesis with Sarah and Amy have definitely helped us refine that a bit more for us, and we've had some great outcomes. So patient feedback has also been quite positive. This was one of our stroke patients who said it was very difficult, and he would say that it was constantly having to take small sips of water was hard at the very beginning because that's all he could take. But his wife has said that they were quite anxious, but now it's a relief that he can eat and drink and it was amazing that he was offered Phagenyx. And at the very end, I'd just like to say thanks to the team, because it wasn't just me. There's actually quite a lot of us to cover all of these patients. And these are also my contact details if people have any queries and want to contact me directly. So thank you.
Super. Thank you so much, Virginia. It was lovely to hear the clinical and the operational benefits of the treatment. I'm now going to pass on to Nia, and Nia is going to share her outcomes from the stroke ward.
Thanks, Amy. I hope you can hear me okay. So my name is Nia. I'm one of the speech and language therapists who works in the stroke service in Swansea Bay University Health Board, down in South Wales. So I'm here today to talk to you about our use of pharyngeal electrical stimulation over the last year, and to show you some of the data we've collected and the patient outcomes we've had when using this treatment. Next slide, thank you. So we've not been using PES for a really long time, but it's coming up to a year now since we initially purchased the equipment, and we've used 10 catheters so far. Our data evaluation is ongoing, I'd say, as well as our partnership working with Phagenyx and our ICU and stroke service colleagues here in Swansea. We don't have huge amounts of time today, so I'm going to provide an overview of the outcomes in relation to the patients we have treated, and then I'll talk to you about one of them in a little bit more detail. So here goes. So all 9 of the patients that we treated were on the acute stroke ward here in Morriston Hospital, and none of them had a tracheostomy at the time of their treatment. The average length of time between admission and their first PES treatment was around 15 days. 66% of them were nil by mouth in relation to fluids, and 78% were nil by mouth in relation to diet. We treated patients with severe sensory dysphagia alongside a variety of other post-stroke impairments, including really quite severe anarthria and severe oral and verbal dyspraxia. For many of these patients, traditional dysphagia therapy approaches would have been really difficult, or they would have been unable to engage, and we may well have had to adopt that wait and see approach that Virginia mentioned in her presentation too. So this is a graph that represents all 9 of the patients and their pre, post and final PAS scores following the treatment. As I'm sure lots of you know, the higher the PAS score, the greater risk that person is of material entering their airway. And as you can see from the graph, the majority of the patients we treated had a PAS of 8, indicating severe sensory deficits with no attempts to eject aspirated material from their airway. Post-treatment, you can see across the board really a continual improvement in the scores and a reduction in their PAS scores. Next one, yeah, brilliant, thank you. So this graph demonstrates the changes in the functional oral intake score. So the voice rating kind of reflects the dependency on tube feeding and the amount of oral intake someone is having. So the higher the score, the less restrictions they have in relation to their oral intake with no dependency on tubes. So as you can see from the graph here, many of our patients were dependent on tube feeding prior to their PES treatment, with all 9 demonstrating an improvement by the final post-treatment phase, where we completed the voice again. For many of these patients, it wasn't necessarily an instant fix and return to normal eating and drinking with no restrictions, but rather a kind of progress and improvement over time. So now we're going to dive into a little bit more detail about one of our patients. So this is actually our second patient that we treated with PES. So she's a 70-year-old female who presented at the hospital with sudden onset of aphasia and right-sided weakness. And she was diagnosed with a left middle cerebral artery infarct. She had severe verbal and limb dyspraxia within her initial assessments, and we hypothesized that she had really quite severe sensory motor or oropharyngeal dysphagia at bedside. She was referred for a FEES, and we recommended that she had an NG, and we kind of offered just water and some sips of water and ice for comfort only pending this. Of note, there wasn't any obvious spontaneous improvement in the initial few days during her admission. Next one, please. So here are some images from the PHEES assessments we completed. So you'll see the first image on the left is the initial PHEES we completed before she received any treatment. You may notice that there's some quite sticky secretions evidence, and she wasn't aware of these at all, and she was unable to clear them from her airway. She had really quite severe sensory motor pharyngeal dysphagia with largely silent aspiration of all fluids and diet textures that we trialled. She wasn't able to adopt any compensatory strategies secondary to ongoing oral and verbal dyspraxia. And without Phagenyx, dysphagia rehab would have been really tricky and limited. Phagenyx is passive. It's a passive treatment where the patient doesn't necessarily need to do anything. So it was great that we were able to offer a patient with these impairments a treatment to target her problems, her dysphagia. So you may notice some colourful graphs either side of the picture. So these graphs represent and reflect the patient's TOMS scores at the point of assessment. So many of you are likely to be familiar with TOMS, the therapy outcome measures that we use. So each of the colours represents 4 different domains. Red is impairment and green activity, blue is participation and purple is well-being. And essentially the more complete and colourful the graph, the less impaired they are in the areas that you're measuring. So for this person, it was their dysphagia. So you can see in a nice visual way that she initially presented with significant impairments affecting all 4 domains, and that she progressed quite nicely following her treatment. The PHEES, oh sorry, Amy, can you just go back a second? Just wanted to, the PHEES image on the right was just taken immediately after her Phagenyx treatment. So we allowed that initial 48 hours and then we did go in and have a look and see what was going on. So given the severity of her dysphagia, we weren't necessarily expecting a complete cure at this point, but we were really pleased to see that there'd been an improvement in secretion management alongside a much better sensory awareness, and her swallow safety with thin drinks had improved. She was able to have thin fluids and her and her family were really pleased. It was a particularly warm week here in Swansea and she was able to have a nice cold glass of squash and her first cup of tea with her family, and she even made it down to the Costa in the hospital. This was huge for her. She'd been completely reliant on other people for all aspects of her care up to this point, and she was able to finally do something really normal and automatic for herself and completely independently. So this is the final image, or the final PHEES rather, we completed with her. So you may notice the image is a little red and less clear. We used the ambiscope, which is a portable endoscopy, because she transferred to the rehab unit by the time that we needed to do this. But essentially the PHEES demonstrated a significant improvement in overall swallow safety and efficiency, and her edema had settled as well. There was no sign of airway compromise and Angela was able to eat and drink with no restrictions. Yeah, so there was a really positive outcome and you can see the colourful graph that goes alongside that too. Next slide. That's it. So these are just 2 graphs demonstrating the PAS and FOIS for her, to demonstrate the before, the post and the final PES scores for the patient. You can see quite clearly that over time, both of them improved quite significantly. So in summary, for this patient and the rest of the patients that we've treated, PES treatment has supported an overall improved well-being, a faster return to oral intake. We do feel like we've helped lower that risk of aspiration, avoid PEG and shorten the length of hospital stay. The next one. So here are a few comments and some feedback that we've received from some of the patients and their carers. So what we noticed when we were speaking to family and the patients is that carer burden, and the impact it's had on the patients as well as the people around them. So yeah, so some people have said it's made a huge difference to our lives, as in not just the patient but the people around them too. And just to finish then, I guess next steps for us here in Swansea Bay is we're going to continue collecting, analysing and sharing our data. We're going to continue working with our stakeholders for sustainable funding streams, continue working closely with Phagenyx, and we are going to continue to present and share some of our work. So we're going back to the Welsh Stroke Conference this year and are presenting at the RCSLT Swallow Awareness webinar, which is Monday. And that's me done. So there's my contact details. If anybody does want to get in touch, they're more than welcome to. Thank you.
Super. Thank you so much, Nia. It was lovely to hear a little bit more about a specific patient. I'm sure we can all picture maybe someone that we've had experience that fits that that description as well. So I'm going to pass on to Alison now, and she's going to be our final speaker. She'll share her journey of implementation. As I mentioned at the beginning, if you have any questions, please put them in the chat or the Q&A box, and my colleagues are fielding them, and we will hopefully have some time in a wee bit to answer a few of those. Over to you, Alison.
Thank you. Hope you can all hear me. Good afternoon, and thank you for asking me to speak today. I'm presenting on behalf of the team from the Newcastle upon Tyne Hospitals NHS Trust. We're one of the busiest and largest trusts in the northeast of England. We have over 16,000 staff, and like I said, we're based in the northeast of England. There's a few little iconic northeast of England things there for you. We're based around two main hospitals, the Royal Victoria Infirmary and the Freeman Hospital. At the RVI, we have a major trauma centre, we have a hyperacute stroke, we have two critical cares, we have burns. There are sort of our main disciplines, amongst other things. Then at the Freeman, we have a world-renowned cardiothoracic centre, with the Institute of Transplantation and the Northern Cancer Treatment. But you'll see from our numbers, despite actually all that, we're quite a small speech therapy team. So we do our best to spread ourselves quite thinly, but we do our best. So where did all this start for us? So a colleague back in 2022 had read about Phagenyx and was very keen to bring it to our hospital. So she got in touch with Bex from Phagenyx, and we were put in touch with the Manchester team, so we spoke to them. And we were very fortunate enough to be offered 3 free catheters and the loan of a base station. And at the time, we had a young man who was admitted. He'd had surgery for von Hippel-Lindau syndrome, and his swallow was absolutely awful. But other than that, he was quite well, but he couldn't go home with an NG tube, and we had nothing to offer him. It would have been like the others the speakers have said, it would have been a sort of watch and wait and just keep our fingers crossed. So we offered it, we thought, right, good opportunity. We offered him this treatment, and he did so well. He was so motivated. He pushed himself to have the highest amount of stimulation that you could, and he did absolutely brilliantly. And from then on in, the Newcastle team has just been hooked on trying to get this treatment for all our patients. So the first thing we did was we got our quotes from Phagenyx. And I think it's important to say that the process, if you're watching this and you're from a trust that's just thinking about getting this, it is different for every trust. But some of the processes we had to go through, I think you'll all have to go through. We were one of the first trusts, so I think since then a lot of things have been learned, and I'm sure a lot of things have been streamlined since then. But having got our quote, the first thing we needed to do was we needed to get approval from the new Interventional Procedures Committee so that we could go ahead and actually do this. And then we also needed approval from the Clinical Outcome and Effectiveness Group, who wouldn't even talk to us until we'd been accepted from the NIPC approval. So it was a chicken and egg getting those 2 bits of approval. We decided to try and get our funding by putting in a business case to our hospitals charity. And then we needed approval from all our different directors of ops, from the different directorates for the ongoing consumable costs. That was a little bit of a stumbling block for us at times. Bearing in mind, we're now 6 months down the line, so we have to get a new updated quotes. And finally, our charities came back to us and said, yes, they would approve this. And rather naively at this point, I think we thought we were all home and dry. Oh no, not quite, but never mind. Because the bid was over £5,000, we had to get approval from our capital management group. We also needed our medical electronics to sign off on it to make sure there were going to be no ongoing maintenance costs, which actually compared to all your fees machines, the nice thing about the Phagenyx treatment is that actually there aren't any ongoing costs associated with that. Finance at this point rejected our capital investment proposal because of the ongoing costs with the catheters. So we had to go back to all our different key stakeholders and get ongoing support from them in order to be able to carry on. Then almost we're talking 2 years down the line from starting the process and putting in the requisitions, getting electrical checks, getting the green light from our clinical governance team, green light from our risks department. The equipment arrived in our department. We were so happy. So what have we learned from that process? Just keep going, just keep on, don't give up. I think the important thing is to find the right people to help you and identify who those people are that understand the process. We were very lucky. We had an AHP business manager who was absolutely fantastic. And as you know, as busy clinicians, we don't have time to be badgering all these different committees. So that was really good. I would also say, and not just because they're on this call, but the Phagenyx team were absolutely fantastic. They are so knowledgeable, they are so supportive, and if they don't have the answer, they will find it for you. And because they're dealing with all of us, they're getting all these answers from everybody. So I would say absolutely use them. You need them in order to help you with the cost savings, and they're very good at crunching the numbers for you and just giving you that invaluable support in writing a business case, which again, as trained speech therapists, we're not necessarily brilliant at doing that. And then you need to get as much buy-in from the stakeholders as you can. Find the people that can influence, and absolutely do not take no for an answer. So what did we get? We got 30 catheters. We had 15 on each site, base station on each site. We got training immediately from Phagenyx, and then we went about, and again, with support from Phagenyx, we made sure we had a SOP. We have a checklist that when we start the process, we can check off and they can go in the patient's notes. We had our consent forms. We even have beautiful do not MRI this patient laminated signs. And we created a big database and we collect everything on these patients. And I would say that's really important for when you're going back and proving how much difference you've made and also your cost savings. So what's it like sort of starting to treat your first patients? And I'm sure the other speakers will agree. It's to begin with, we were quite slow at selecting patients, but we're obviously getting much better at that. We are so invested as a team. When we have a patient who's going through the treatment, we all want to know. We have people on annual leave who will phone up when it's somebody's having a post-treatment fees because they want to know what the outcome is. They want to know how the patient's done. And the other thing we do is we make an awful lot of song and dance about shouting about our success to anybody that'll listen, to be honest. So to our consultants, to our nursing staff, to our physios, and just kind of getting word out there. So we've treated 15 patients so far. 5 have been stroke. They've been a real diverse group of etiologies from Guillain-Barré, ACD&F, polytrauma, liver failure, lung transplant, aneurysms, fenestrated endovascular aortic repair. So there's very, very diverse. And the results have actually been really good. I think the important thing to state is that none of our patients had a mild dysphagia when we started. They all had severe dysphagia. They were all PAS-8. We've improved their sensations, we've improved their secretions. With their digest scores, they've gone from a severe to a moderate. They've all had improvement in the secretion management. Functional oral intake scale, they've gone from all of them being nil by mouth to all being on some sort of oral intake, even with some sort of special preparations. And the dysphagia severity rating scale, they've gone from severe to mild and moderate. Having a little bit more of a deep dive on that, all our patients have been nil by mouth. 60% were on oral intake post-PES. And then further assessment, and I think another speaker's alluded to this, we find that they don't immediately make that recovery. And in fact, we've learned that we're often pushing that first phase back a little bit just to give them a little bit more time to recover. But even when we do the first phase, we're then seeing improvement on the second and the third phase. But further assessment, again, so that by the end, 73% were on oral intake at the point of discharge from us. And even one of them was actually eating and drinking at risk successfully. So maybe it wasn't actually that risky. and also to highlight that of the 11 patients that were on full oral intake, 82% were on level 0 fluids, level 7 diet, 18% were on level 1 fluids, level 7 diet, which was absolutely brilliant. And then overall, 60% of the patients that returned, so effectively 6% of our patients returned to normal diet and normal fluids. Like I said, we like to shout about this. And often it's really improved our kudos, it's improved our profile as speech and language therapist. You go on with this fancy bit of kit and people really like it. We were lucky enough to win the Innovations Award, and that was really nice because people who would never really hear about this actually got to hear about it, especially on critical care. Our anaesthetists, our consultants on there, intensivists are very interested and very keen on the treatment. And we've even been in a sort of slightly awkward position of getting phone calls from relatives who've obviously read about these things on social media, other trusts who don't offer the treatment yet, wanting to get their patients treated. So it's obviously there is a need for it. So I think we've got a really nice foundation in place now. Like I said, you need the publicity because we've still got the ongoing funding. And I think we've changed our mindset now. Instead of kind of going, are we going to give this patient PES, we're now thinking, well, why wouldn't we give them PES? There's often a whole host of reasons why we wouldn't, but we automatically think about this when we have somebody who we put nil by mouth following a FEES. I think our goal of care has changed in that we're not just thinking about getting people eating and drinking, but we're looking at trying to improve airway and secretion management. We had a lovely lady just before, a couple of months before Christmas, with really severe Guillain-Barré. She had a tracheostomy. She was struggling with secretions, trying to get her cough down. And our goal was to treat her and to try and get her decannulated. That was our goal. We gave her the treatment. She was absolutely lovely. And she actually got transferred to another hospital as soon as we'd finished the treatment, which was really unfortunate. But they did the post-treatment fees for us. And they got her eating on Christmas Eve, which was just absolutely fantastic. And she still continued to improve. And really interestingly, this lady, you know, you always do wonder, don't you, was she just going to get better? This lady is now in rehab and is really, really struggling from a physical point of view. But interestingly, her swallow has way ahead of everything else. So I think that's really encouraging. And keep collecting the data. You've really got to keep that data. So where are we at now? We would really like to get to a situation where we have got some protected pots of money. We're not at that stage yet. We don't want to be at the stage where we have to go through this process every time we want a new catheter, because we're getting towards the end of the catheters that we've got. So we're working on a business case, again, with fantastic support from the Phagenyx team to try and push forward to that. And I think the biggest thing is that our AHP manager said there's not many things that he can go to the bosses and say, this, by spending this is how much money we can potentially save. We would love to treat more patients, and we would keep shouting about it so that we can keep ongoing support for doing this. Thanks very much.
Brilliant. Thank you so much, Alison. So as I said, that is our speakers for the day. I hope you have all enjoyed listening to them. We've got a little bit of time now, so I'm just going to have a look to see what the questions are. Or Sarah, if you have the themes there. Okay, so.
Hi, so we don't have a huge number of questions at this point in time. There have been a few site-specific ones that I've kind of answered. One really interesting one asking about whether we can use it as a preventative treatment in intubated patients. And if you want to have a look at the answer in the chat, but we do have research evidence around treating in intubation, specifically around stroke, showing that if you treat prior to extubation, you are likely to have a less chance of being re-intubated post extubation. So you're more likely to have a successful extubation. I should phrase it that way. Thank you. So that's really interesting. We will send out a sheet with our research studies on it at the end to the email addresses. If people are interested, they can have a little look at that. If there's any other questions people want to drop in the chat, please have a look and do so now, and we will do our best to answer them for you, or ask any of our panelists a question around what they've presented. I'm just going to throw you all out there about what they've presented today.
Sorry, Sarah, I can see that there's a question about the timescales between our initial post-treatment objective assessment and the voice. Is that for me specifically? Because you've put my name in there.
It is for you specifically. I didn't know if you would specifically know that exact number, so I wasn't going to throw it at you now.
I think I do have that actually. Let me just get it up. On average, we did a FEES a median of 5 days post treatment, but it did range from 2 to 19, and it's similar to what the other speakers have said. We did find that if we FEESed at the beginning, maybe we FEESed patients a little bit too early post treatment, but then we found that later on, if we waited a few more days, we'd actually have better outcomes. And it also was a bit more efficient rather than FEESing a patient 2 times in 1 week. We just would FEES them the 1 time after treatment. So we did wait. By the end of our pilot project, we waited a few more days before we repeated the FEES assessment. And then in terms of like discharge, we would probably, by that stage, the patients had improved so much that we could just do bedside assessments. And so a lot of our discharge outcome measures around eating and drinking, diet and fluids was just what was recommended from a bedside assessment. I hope that answers the question.
Thanks, Virginia. That's really helpful. Just looking at the other questions here. So we've got a question around NICE guidelines and NICE guidance. I think it would be something that obviously whenever you go to speak to your organisation, NICE is going to come up. We would always talk to you about that NICE give us a guidance. They don't give us a guideline. So when we are treating our dysphagic patients, we'd suggest that you kind of look at, well, what is available within NICE at the moment in relation to dysphagia treatment? And the answer is really that there isn't very much. This is the best research piece of dysphagia therapy that is out there at the moment. So it's a case of taking that, looking specifically at your caseloads and taking the research evidence that is out there back to your organisation and discussing that with them in relation to the caseload that you're working within. And then feel free to come to myself, Amy, Bex, anyone within the company, and we will help you with that discussion with your organisation at that point in time. We just have a quick scan down.
Any other queries? As I say, you had our contact details there, so do feel free to reach out to us just across a few different platforms. We'll just wait, see if there's any other questions.
Question around time to decannulation. Yes, there is research evidence around the fact that patients who are treated are decannulated quicker post treatment. And again, that study will be on the flyer that we will share with you.
Yeah. So Sarah will share the key publications, and just also to add about NICE. So there's a FEAST study going on at the minute. So it's a large dysphagia study. It should be completed at the end of September and then published in due course. So we'll be returning back to NICE once we have the evidence from the FEAST study. And that will be reviewed. As a recent update, more current update in terms of the guidelines, as I mentioned at the beginning, was that the American Stroke Association guidelines came out this year. So they're the most recent guidelines that have referenced pharyngeal electrical stimulation.
And then lastly, Deborah's asked if there is any specific guidance on which non-tracheostomized stroke patients are most likely to benefit from PES in terms of type of stroke, NIHSS scores, etc. At this point in time, evidence suggests that there is no difference in the type of stroke you have or the location of your stroke. All stroke patients are responding in the same way to treatment. So there's no, at this point in time, narrowing down of those patient groups.
I just spotted a question there about exclusion criteria. So there are contraindications for use that we can share with you. You mentioned there about cardiac patients. Some of the group here that has spoken, they have treated cardiac patients that have a neurogenic dysphagia. Contraindication of note is that if they have an implanted device or a severe cardiac or respiratory condition that would prevent the insertion of a catheter, then they're not suitable. But we can talk to you a little bit further about that if needed.
I think that's covered the main themes.
There's a question there just about medical diagnosis success. I think just to touch on the evidence base, the key publications areas are predominantly in tracheostomised patients with a neurogenic dysphagia or stroke patients. And then we have some other evidence of people treating examples of the real world evidence. So we can send you out the key publications so you can have a look over yourself. So a question about non-verbal or patients that are lethargic, and can they get treated with dysphagia? And it's like, yes, this is one of the key advantages of Phagenyx, as it's a passive treatment. So that doesn't involve any involves minimal active participation, allowing the speech and language therapist to get in there earlier, so they can provide treatment earlier before if someone can't engage with your traditional speech and language therapy approaches. You can do this as your base and then build on it.
And then just another question about what, in terms of timing of treatment, whether you sort of treat early, late, medium, sort of further down the line, and what the response rate is. There's certainly research evidence and real world evidence out there to say that we have impact all stages along the care pathway. So obviously in an acute phase, we'd encourage you to treat as early as possible so that you avoid the downstream issues of dysphagia in an acute environment, but also research that says, and study evidence that says, treating further down the line can have an impact and a positive impact on your patients. And even a small amount of research sort of 18 months post-stroke saying that it is possible to make change in these patients also. So yeah, at any point in their care pathway, it can be appropriate.
I'm just going to reshare our contact details there. And we will conclude our webinar. Thank you so much for joining, everyone. It's been really great to have you here this afternoon, and many, many thanks to our speakers for sharing their experience.